Good evening, all. I'll be presenting a case we have titled as A Tale of Juvenile Beating Heart. This is a case of a 16-year-old boy who presented to us with a history of 1.5 years in February 2023, with history of fever, which was undocumented on and off, which was relieved with antipyretics, and there was no specific pattern associated with it. It was associated with arthritis, which was lower limb predominant, which was symmetric, non-deforming, involving both small and large joints, including knee, ankle, and wrist. This was there for the period of 10 months. After that, the patient developed proximal muscle weakness, which was initially in the lower limbs, followed by involvement of the upper limbs. It was symmetric. There was no bulbar or neck involvement. 4 months later, patient developed rashes over bilateral elbow and MCPs and PIPs, and also had a malar rash. Initially, the rashes were only macular. Later, they became papillar and papillonodular. The lesions on the MCP and PIP later ulcerated, and the patient presented with active discharge from those ulcers. He did not have any history of shortness of breath, Raynaud's phenomena, chest pain, oral ulcerations, alopecia, or any other CTD-related history. There was no history of similar illness in the family members or any history of autoimmunity. Patient, he was born out of non-consanguineous marriage. He was full-term normal delivery with no complications. There was no significant past history or any history of recent vaccination. There were no milestone delay, and he was vaccinated for age till 5 years of age. On general examination, there was no pallor, icterus, cyanosis, clubbing, or edema. There were ulcerated gauntlet papules over the right third MCP and left third PIP with active pus discharge. And there was restriction in flexion in both the joints. And there were papillonodular lesions over bilateral elbow, right second and third PIP of toes. On musculoskeletal examination, the MMT8 was 56 with a weakness in neck flexors of 5, biceps of 6, deltoid of 6, quadriceps 7, gluteus medius 7, and gluteus maximus 5. And the left ankle was tender and swollen. Other systemic examination was within normal range, and the gag reflex was also present with no sensory deficit or cranial nerve deficit. On lab workup, he had elevated ESR of 37 with CRP of 18. His markers of AST was 108 and ALT was 69. CPK was within normal range and LDH was mildly raised. We did a chest X-ray which was within normal limit. We also did an X-ray of bilateral elbow which showed no underlying calcinosis. We did ANA which was negative, and MSA panel showed MDA5. And we also did, in view of active pus discharge, we did the serum procalcitonin, which was within the normal range, and the pus cultures did not show any organisms, and AFB CBNAT was also negative. We did the X-ray of the hand, which showed osteolytic lesions with irregular bony margins and osteosclerotic lesion in the middle phalanx of the left third finger. And on the right side, where the other ulcer was present, there were no similar changes on the same. We did the MRI of the left hand, which showed T2 stirred. In the T2 stir sequence, there was intramedullary hyperintensity, and there was surrounding soft tissue edema. Along with there was post-contrast enhancement, and there was thinning of articular cartilage, which was consistent with osteomyelitis. Rest of the muscle compartment and bony structures were normal. So we diagnosed the patient as MDA5 dermatomyositis with components being myositis, arthritis, cutaneous, and osteomyelitis. So we started the patient on 1 mg per kg steroids, which was 35 milligram of prednisolone. Empirical antibiotics were given for 6 weeks because of underlying osteomyelitis. After 1 month of completion of antibiotics, we started the patient on methotrexate, and gradually we increased the dose. And over the follow period, the patient's MMT8 improved to 80 by 80, and the ESR started settling, and muscle enzyme markers were also settling. And there were no active discharge, no active joints or pus discharge. In August, when we reviewed the patient was on methotrexate 25 milligram, and the prednisolone was tapered to 7.5. Patient had no active disease markers, but there was whitish discharge from left elbow. So we thought maybe patient was having a new calcinotic lesion. We did a X-ray, which did not show any underlying calcification. We had sent a pus culture also, and we started the patient on antibiotics for 2 weeks, and the pus discharge resolved. The ESR at that point of time was 35 and CRP was 2. The patient got admitted in September 2023 with history of fever, cough, and shortness of breath for a period of 1 week. The chest X-ray showed infiltrates in bilateral lower zones. The sputum gram stain culture was negative, and even for the viral panel we did not find any organism. The CRP was 52 at that point of time. ESR was 58. The patient did not have any disease-related flare. The patient was treated as viral pneumonia, and he improved with symptomatic measures. After 2 weeks of this infective episode, patient was restarted on methotrexate, and patient continued to take it till November 2023, and he was absolutely fine. But later, the patient was lodged to follow up, and he defaulted his medications. Then patient was readmitted in February 2023 with history of fever for 1 week, which was associated with dry cough, and it was followed by shortness of breath on exertion for over a 1 month period, and it was gradually progressive from MMRC grade 2 to MMRC grade 3. And he also had concomitantly proximal muscle weakness involving bilateral upper limb and lower limb. There was no history of chest pain, palpitations at this point of time. On examination, his BP was 110/70. However, he had tachycardia, which was regular. The saturation was 92% of room air, and he had pallor. There was a new calcinotic lesion at the right heel, and there was reappearance of the Gotran's rash over elbow, and there was inverse Gotran's on the palmar surface of the fingers. The MMT8 was 56/80, and he had palpable second heart sound, and P2 was also loud. They were found in inspiratory crypts in bilateral infra-interscapular region. The single breath count was 25. The 6-minute walk distance was 385, which was done once the patient was stabilized. Rest of the examination was normal. So on workup, there were elevated ESR, CRP, and there were lymphocytes were on the lower side of normal. There were raised muscle enzyme markers, SGOT and SGPT, and LDH was also raised. Ferritin was 283. The patient did not have expectoration, but on sputum induction, we did send it for culture analysis, which was negative. On T2D echo, there were no RWMAs. Ejection fraction was 60%, and he had mild pH of MPAP of 32. The anemia workup also showed anemia of chronic disease only. Then we had a confusion whether that is infection or whether it is ILD. So the X-ray showed increased reticulations in bilateral lower zones, and the CT showed bilateral subdural reticulations, which were lower-low predominant with interlobular septal thickening, multiple consolidatory patches, and ground close opacity, and the extent was less than 20%. There was also mild pneumomediastinum. So because of the presence of consolidations, we did a BAL, which was also negative. So because the chronology or the duration was a very short period, hence we treated the patient as ILD NSIP along with superimposed LRTI. So we gave the patient 0.5 mg per kg corticosteroids in view of myositis flare along with antibiotics and antivirals, which were continued for 2 weeks. However, the patient revisited OPD after 21 days. His myositis had improved. The cutaneous features had started to resolve, and patient was able to maintain saturation and room air. The shortness of breath had improved, but the patient presented with palpitations on exertion with no chest pain. We did a PFT at this point of time, which showed FEV1 of 65%, FVC of 57%, the ratio of FEV1 by FVC of 112%, and DLC of 45%. He had persistent tachycardia with a heart rate of 140. This was the ECG of the patient, which showed sinus tachy with STT flattening and shortening of the PR interval. So we started evaluating for other causes of inappropriate sinus tachycardia. The TSH was 9.6. The anti-TPO was normal. Cardiac biomarkers were normal. Anti-proBNP was also normal. So we were not able to find the cause for this. So we went ahead with a cardiac MRI. The cardiac MRI showed T2 hyperintensities in the apical region, in the mid cavity, and the basal region, which were consistent with myocardial edema. There was endocardial edema along the apico-anterior, apico-lateral, mid-anterior, and mid-enterobasal, mid-enterolateral, and basal segments. There was PH and mild MR. So this was our final diagnosis. We started the patient on 1 mg per kg steroids in view of active myocarditis. We gave cyclophosphamide as a steroid-sparing agent. Tadalafil for PH. We vaccinated the patient, added topical tacrolimus and beta blockers for heart rate control. This was the follow-up ECG. Currently, patient is doing well. His MMT8 is 80/80. 6-minute walk distance has improved. His skin lesions have also improved. So the learning point from this case was we need to suspect myocarditis in events of unexplained dyspnea and tachycardia. We need to do active search despite screening methods being normal and to always have a high index of suspicion. In literature, approximately 75% of patients in adults are reported to have cardiac involvement. In children, up to 22% are reported to have cardiac involvement. In MDA5, it is infrequently reported. However, subclinical cardiac abnormalities are still reported in up to 50% of the cases. The predictors of cardiac involvement include higher MMT8, bulbar involvement with ILD, and positivity for SRP antibodies. Association of anti-Rho, PMSCL, and AMA antibodies are also associated with cardiac involvement. Also, cardiac troponin T is generally elevated in patients of myositis, so it might not be a good marker, even though it has higher sensitivity. Cardiac troponin T is more specific and has specificity up to 95% and a positive predictive value up to 62%. NT-proBNP also has a sensitivity of up to 93%, and ECG abnormality can be found in up to 85% of patients with non-specific STD changes. We need to go for better imaging. If we are not able to find these abnormalities, we can go for cardiac MR. We can go for FDG PET with specific newer perfusion, which also includes perfusion imaging and SPECT. Thank you.